So we're very pleased today to have a very interesting case presentation from Glen in Ulaanbaatar. And I will turn the microphone and the talk over to her to discuss this very distinctive case. And then we'll have some discussion about that.
Okay, hello everybody. My name is Gyn, and today I will present a case about polyarteritis nodosa in the ovary. And I'm a first-year pathology resident doctor at Mongolia Japan Hospital. So about our case, we admitted a patient with 58 years old female who has right lower quadrant abdominal pain. And about her past medical history, she had a thyroid gland disorder and also a benign tumor of the salivary gland, which is removed. And about her gynecological history, she was postmenopausal since 2019 and G6P4. Also, she was diagnosed with ovarian cyst about 20 years ago. Next slide, please. About her imaging tests
Sorry, is it just mine or I don't see any slides?
Do
everybody see slides?
I'm
Oh,
able
I'm sorry. I see it.
Yeah.
Thank you, thank you.
Okay.
Are we okay on the slide?
Yes, it was just me.
Okay.
Okay. About her abdominal ultrasound was it revealed that her abdominal organs such as liver, gallbladder, pancreas has normal size, and there was no focal lesions or anything serious. And in her right ovary, there was a cyst measuring approximately 6 centimeters. Next slide, please. And her chest X-ray was quite normal, which was there was no focal or infiltrative lesions. Next slide, please. And about her transvaginal ultrasound revealed that there is also cyst in the right ovary, which was 5 centimeters. And 2 months after that, she had an abdominal computer tomography test, which revealed that the cyst size slightly increased, that it says 7 centimeters and with thick wall and homogeneous density, which that's why the clinicians thought that it might be benign or a malignant tumor, and they did the surgery. They warranted surgery, and they did it bilateral because she was postmenopausal. And about her clinical tests revealed that her white blood cell is slightly elevated, as you can see in the blue, and other test results was quite normal. And next slide, please. And after the surgery, we received the specimen, and this is the gross description and the microscopic picture of the specimen, which was bilateral at NAXA. And the right ovary consists of 10 white blue tissue with multiple simple cystic spaces measuring 7 centimeter in the aggregate. And the left ovary measures 2.5 centimeters and grossly unremarkable. And right and left fallopian tube measures 5 to 6 centimeters. And as you can see, upper side of the picture shows 2 fallopian tubes, and the multiple consist of white 10 tissues are the ovarian tissue. Right.
Was this surgery? Do you know, actually, Glenn, was this laparoscopic surgery, or do they have that technique in Ulaanbaatar?
I think that was laparoscopic surgery, but I didn't have a chance to talk to the surgeon, so it's just the specimen that we received. And next slide, please. In this slide, this is the microscopic findings, which you can see that there is many arteries that has a thick wall, and thick wall in its wall there is a lot of inflammation with so many lymphocytes and neutrophils, and we can see the bigger magnification in the next slide. And as you can see, there is a fibrinoid necrosis with rupture of the internal elastic lamina and transmural infiltration that extends to the perivascular tissue, and necrotizing and non-granulomatous inflammation of small and medium-sized arteries. So infiltration by it is neutrophils and lymphocytes leads to vascular fibrosis and thrombosis. Next slide, please. So after that, we made the final diagnosis that she was in her ovary. It was consistent with polyarteritis nodosa, and in her left ovary, there was no pathological findings, and fallopian tube was only with congestion. And we consulted this case with the Dr. Konzi on case IO because we didn't know which was we didn't sure about this case because it was quite complicated, and our teacher consulted this case with other professors and other pathologists, so they made the final diagnosis with polyarteritis nodosa, and we didn't find anything about the cyst, and there was no simple or other cysts in the ovary. So this is the final diagnosis. And next slide, please. And so we researched a little bit about what is actually about polyarteritis nodosa, and this is multi-systemical and small and medium-sized inflammation, and it is more common in men, 2:1 or 3:1 ratio, and it can affect any organ except lungs, and it's quite rare but fatal disease, and it can affect mostly small and medium-sized vessels. Next slide, please. And about this disease, it can occur about 30% cases of associated with hepatitis B virus, and perinuclear pattern of anti-neutrophil cytoplasmic antibodies and C-reactive protein and ESR may be elevated in this case, in this disease, and diagnosis will be confirmed by histopathological examination. And next slide. So also we can do the immunofluorescence tests for the vasculitis if we wanted to diagnose it, and to see the deposits of the IgM or other complex in the vessel walls to confirm the diagnosis. But this is not our case's picture. I just took this picture from pathology outline site. We didn't have a chance to make the immunofluorescence test. So next slide, please. And this is quite rare, so I searched a little bit, and I found this article in PubMed, which was isolated ovarian polyarteritis nodosa. And this is quite similar to our case, which was it is also happened in ovary. So, and they mentioned that it might be the first one to be published in the literature. And next slide, please. So we have to consider other possible diagnoses, like differential considerations will be thrombocytopenic purpura and senile purpura, embolism and infections, drug-induced vasospasm, vascular trauma. So we have to think about anything related to vascular diseases. And also we have to make, if you wanted to make final diagnosis, we have to check the patient's clinical results and imaging tests, and the clinical pathological correlation is really important for this case. And also Dr. Kunze that we discussed this case about also mentioned that we have to consider clinical pathological correlation. And he also said that it might be isolated ovarian polyarteritis nodosa. And next slide, please. So I have two questions for you, for the participants. And I before that, I wanted to make my final thought about this case because in our case that she only was diagnosed with benign ovarian cyst, and they just thought that it might be benign simple cyst or serous cystadenoma or something like that, and she carried this cyst like 20 years. She carried this cyst for like 20 years, and the clinicians also, other doctors thought that it might be just a cyst, but turns out after pathological examination, we found out that it might be systemic vascular disease. So I just thought to myself that we have to think bigger. We have to think like outside of the box, and we just have to make sure that pay attention to the other side of the slides. Like we have to see every part of the slide. So if diagnosing this disease is very very helpful for the patient's diagnosing process. So this is quite interesting for me. So I wanted to ask these questions for you. Have you ever seen a case of polyarteritis nodosa in the ovary? This is the first question. And the second question is, what are your thoughts about the patient that we talked about and the fact that she did not have any systemic symptoms of vasculitis? So is there anybody who wants to answer these questions?
Wonderful, wonderful presentation. And I have a few questions additionally to these that we've seen, and partly they relate to follow-up decisions. So I'm sure once you made this diagnosis that it was a surprise to the clinical team. And so first of all, was she still hospitalized when you rendered your diagnosis? And so could you do some additional testing like sedimentation rate or like C-reactive protein to see if she in fact might have other blood or chemical evidence of inflammatory reaction going on elsewhere?
When I found out this case and she was not in the hospital, it was when I went to I was in the other clinical rotation. So after this case has been diagnosed and treatment has been made, after 1 or 2 months later, I went to the hospital that.
Yeah, okay.
Yeah.
So do you know, did she receive any steroid treatment or any, I mean, what would they call the patient back and,
Yeah.
propose a plan of therapy?
Yeah, our teacher said that she connected with the clinical doctor who was treating her, and her clinical doctor said that they will change the treatment plan for her about making her take the glucosteroids and other medications.
Okay. So there's at least a concern that she may have systemic disease, and that's why they would give the medical treatment, which is not totally benign, but not certainly highly aggressive.
Yeah.
Another question here is, do you think that the polyarteritis was the factor responsible for the cystic lesion? In other words, was there a separate cyst or other benign structure, and you just happened to identify polyarteritis in the vasculature, or was the inflammatory process actually giving the impression of a cyst?
Yeah, I asked about that if there was any evidence of being a cyst in the ovary, and they said that they did not find any cyst in the. Maybe they said that it maybe it was collapsed, or um, they didn't find any evidence of cyst cystic lesion. Maybe they just cut through the wrong section of the gross on the
Mhm.
microscopic on the specimen, and um, I think it might be the about the vasculitis. They can trigger the cystic lesion in the ovary. I just thought that it might be the causes of the cyst, but we cannot prove fully that it vasculitis can trigger the cyst. We cannot make we cannot prove that.
So Esther, you want to make some comments or bring a question
Oh,
up?
yeah. Thank you so much for the presentation. I actually never seen a case of polyarteritis nodosa isolated in ovary. So I think that was very interesting. And you only found one case report, right? So that's so rare. Um, did you find more or was it just only one?
About case reports,
Mm-hmm.
maybe I did not use the end note, so
Okay.
I didn't have end note that time. So there might be other cases and other research in the other sites.
Okay.
My I just searched it in PubMed, or my surgical my search was not really wide.
Oh, that's okay.
It
But
was quite
nevertheless,
short.
I think it's pretty rare to have it in the ovary. It's, more
Yeah,
common like in the skin or kidney first.
yeah.
So when you saw the sections, was it very frequent to find these arteries? So is it well like globally affected or focally or
Mm,
what was the extent of involvement?
I think it was focally affected, and
So you had to really
um,
search for the arteries with the disease.
um, pardon?
So when you saw these changes, like the necrosis in these
Mhm.
arteries, was it very frequent that you didn't have to search for it on your slide, or was it easy
Oh,
to find?
I think it was pretty frequent that we
Mhm.
did not have to find hardly to,
Okay.
yeah.
And there was nothing on the other side of the ovary, right?
Yeah, they're just the right ovary.
Is it right?
And left ovary has no pathological findings. It has just
And
normal
she,
histological.
and remind me, how old was she and what was her symptom?
Um, 50 years old,
Mm.
and she was diagnosed the right ovarian cyst with 20 years ago. But she did not remember the whole exact diagnosis, what she really has, what kind of cyst it
Mm.
was.
But it wasn't causing pain or discomfort. She just wanted to get it removed.
Yeah, it's quite big, and the clinicians thought that she's already postmenopausal, and we can do the bilateral surgery for her
Okay.
to get rid of pain. Maybe they wanted to left anything serious for behind.
So she did have pain?
Yes, she had pain.
Oh,
Yeah.
okay.
Yeah, right abdominal quadrant, lower quadrant pain.
Oh, okay. Nice. Okay, cool. Thank you.
Thank you. Thank you for your attention.
So I can imagine that this would have been a difficult frozen section if they had submitted tissue for frozen section. I'm grateful that I was not asked to consult on a frozen section on a case like this because that can be so difficult. But at the same time, it does underscore the fact that, you know, if we have a fairly rapid turnaround on samples like this, that sometimes we can catch the patient still in the hospital and alert the clinician to, you know, maybe an unsuspected diagnosis, so that they can get the patient to the proper treatment or consultant sooner. And in fact, many hospitals have a policy actually for communication of unexpected results. This would certainly be, you know, a potentially unexpected result. And because polyarteritis nodosa has, you know, a fair bit of mortality if it's systemic, it would certainly fall into that category where you would want to make sure that as soon as you're suspecting that possibility, you notify the clinician that this is unexpected and potentially significant finding that requires some further evaluation and workup. And when you do that, of course, you want to document, you know, who you talked to, how you told them, all of that sort of thing, so that you can, you know, provide evidence that you went to the level of significance in communicating results that would be appropriate. That actually is a requirement on the CAP checklist when your laboratories are accredited by CAP, that you have a written policy for communication of these kind of results and the documentation of that communication. But even if you're not CAP accredited, I recommend that you have that kind of a policy and practice written down and recorded in your laboratory procedures. Meanie, do you have any other comments or reaction to this case from your experience?
No, I thought it was really interesting. I had never seen a case of polyarteritis nodosa in the ovary either. And yeah, I think it's really it's I was thinking more about what happened to the cyst because we kept thinking like this is the reason they did this surgery to begin with. It had grown in size, it was concerning. But I think it's interesting to see that like maybe these inflammatory conditions can create imaging findings that mimic other things potentially. And looking back on her, Iecheglen had mentioned her white count was a little elevated. Maybe there was some underlying thing that just never really got picked up. So I think it's very cool how histology can translate to the clinical medicine practice.
I
Yeah.
also
And she was also slightly anemic, which I
Yeah,
think,
yeah. Mhm.
and someone's postmenopausal, you probably shouldn't ignore that.
Right, right. Yeah, yeah. Mhm.
No, it was the gross picture you showed us was really good because it looked like it was collapsed cyst with white membranous. So I'm
Mhm.
sure I think there was
I think she has
probably a
simple
benign.
cysts. Yeah.
I'm sorry? Yeah, simple
Yeah, I
benign
think she has
cyst.
benign simple cysts.
Right.
We were talking about that. I think there's like, but nothing like a 7 centimeter type of lesion.
Yeah,
So yeah, it's interesting.
it's cool.
Mm-hmm.
Oh, sorry, one more question. So these findings of the fibrinoid necrosis and arteries, was it like when you're looking at grossly with those white membranous tissue and fragmented ovary, would you be able to pick them up where it would be, or it was just in everywhere I mean, grossly, was there different areas that you might suspect the lesion would be? Because when we're sampling and we're doing like gross examination, it's really important to sample the right area.
Mm, there was few white areas, and I'm pretty sure that I included those white areas
Okay.
into the cassette.
Yeah, makes sense. Thank you.
Thank you.
Yeah, it was obvious that there was the larger, I mean, it was the hilar vessels were what were involved, at least in some of those areas. And if you just have a native or ovary without the cystic or fragmented changes from, maybe um, laparoscopic extraction, you might actually not sample those arteries as thoroughly as you would need to detect this. So I think there's certainly a potential to miss this diagnosis if your sampling doesn't include the hilus of the ovary.
Mhm.
What? Okay, well, I have an interesting case that I thought we could also present for discussion today from a very recent case that came to my attention. This is a 45-year-old woman who had an abnormal pap smear with atypical glandular cells. And when you get to the GYN cytology module, you'll appreciate what that means. But they did a fairly generous cold knife cone biopsy, which means that they didn't use a lot of cautery, and resected her cervix. Whoops, here we go. Been on the site too long here. Oh dear, here. Let's see. So I'm going to have to stop share so I don't give away any medical information here. While I pull this back up, I had it all queued up and then um, it's gone forward. So she had that abnormal pap test, um, and um, I think that she also had a biopsy that showed abnormal glands. Um, Sorry for this delay, technical problem. Um, okay, now I can share again. So just for your benefit, the United States has very strict penalties if you disclose patient clinical information in a setting where it's not appropriate. And so I have to, but when I have that setting on my viewer here, I can't look up the case quite as easily. So anyway, here's a section of cervix. And as you see, it's mostly glandular tissue. As we get over here to this end, you can see a little bit of squamous mucosa and the underlying benign endocervical glands. So you see that. So this is probably the exocervical aspect. And here at the other end is the endocervical aspect. And here it looks a bit different. It looks kind of busy. We have a benign cystic structure here in the middle. And then we have, as you can see here, some darker hyperchromatic tissues here. So this is, I think, a nice opportunity to compare endocervical adenocarcinoma, as you can see here, This is a lesion that's characterized by nuclear crowding, oftentimes some apical mitotic figures, which you can see here. In other words, they're towards the lumen side of things. And then some apoptotic debris and nuclear debris and so forth. And this contrasts nicely with the more normal endocervical gland here and over here. So even here in between, we see a fairly normal endocervical gland with the contrasting hyperchromatic glands. So one of the challenges with endocervical adenocarcinoma is that it very often doesn't provoke much of a tissue reaction. And so it can be quite difficult to decide what's invasive and what is just extending down and multiplying within pre-existing glands. So here we have an endocervical gland that's benign, that's quite deep. And similarly over here, these are benign glands here, and the abnormal glands are at about the same level. Even here in this additional site here where I measured a maximal dimension, this isn't deeper than this other gland here. And obviously these are somewhat hyperchromatic. Again, you've got the apical nuclei and so forth. So, and I don't know, maybe Esther or Padnini have other experience, but I find it very difficult oftentimes to decide, is this invasive or is this still in situ disease? So oftentimes we will just give a total thickness of the lesion, which is kind of what I did here, just to measure the total thickness. And that will help the clinician decide, do I need to do a simple hysterectomy or a radical hysterectomy based on this depth of extension? There's one other very unusual feature here, and maybe some of you picked this out, but if you look here, even though we didn't have any surface squamous disease, here in some of these glands we have obviously solid squamous type epithelium right opposite of areas of adenocarcinoma as well. So very often, because the majority of endocervical adenocarcinomas are HPV related, you can have a combination of squamous and glandular disease in these cases. And we'll take this a step further here as we look at another slide. So here you'll see we put ink on the endocervical margin. This blue coloration here on the edge of the sample is a graphical proof for us that the neoplastic process extends to the endocervical margin. And I think we can even see it's down here fairly deep at the margin as well. So I measured this on several different slides, and this actually was the largest measurement, which was over 6 millimeters of extension. But one of the things that was quite interesting to me initially was these kinds of areas here. And so, although this area looks a little bit different than some of the other areas, you'll notice that there's not the same degree of hyperchromasia here. And in fact, many of these nuclei look maybe relatively normal, but we have mitotic figures that are present here. And I started circling some of them so that they would stand out. Here's a couple of them right there. and so forth. So there's not the same degree of crowding that we had in that more superficial area of this lesion. And to my eye, this was reflective of a pattern that we call a minimal deviation adenocarcinoma or adenoma malignum. And I don't know if Esther or Mini won't want to agree with me on that, but I haven't seen it very often, but this looked like a fairly good example to me of that kind of change, particularly when we had the other areas that showed such much more characteristic or typical endocervical adenocarcinoma type of pattern. So that's my first question I would ask my colleagues here. Have you ever seen these two patterns in the same patient, in the same lesion?
No, I'd be
I,
scared because
yeah.
the minimal deviated adenocarcinomas are always negative for P16, and other than the mitotic, like increase in mitotic figures and architectural atypia, I'd be like, oh, a little bit worried. I wouldn't know. Yeah, it's a challenging case.
So yeah, exactly the point. And then I'll show you the P16 stain that my colleague who sent the case in was not on a block that had this minimal deviation type change. So that was that was a little bit concerning. But here, as we look at the surface, again, we can see this much more characteristic, typical type of endocervical adenocarcinoma, even here, right, juxtaposed a more normal area of epithelium here. So another question is, could she have two things? Could she have a typical HPV-related endocervical adenocarcinoma and adenoma malignum? Well, that would be two uncommon events occurring in the same patient. So we usually don't like to do that. But there, things that are strange happen. There's one other feature on one of the slides here that I wanted to show. And let me see if I can find that slide again. May have to look through a couple of these slides to see if I can find it. That's not one. Let's okay, this one. Nope. This one. Nope. So I did use the highlight tool, and that I can see which slides have sort of annotations on them to find that area again. Yeah. Well, I've now been through almost all of my slides here, and I haven't found the area that I was concerned about. Oh, here it is. Here it is. So here is, we'll just sort of give you a little bit more context. Here's an area where we have more of this, almost solid, high-grade stuff that's sort of in between glandular and squamous. It's sort of piling up, but it's not quite rounded out like it's a squamous lesion, and you have this necrotic material in the lumen. But then here adjacent to this, we have areas where you begin to see some sort of stratification here occurring in some of these cells. And then you can see we've got significant nuclear atypia here, but notice that we have a mucinous change to many of these cells. And so I believe that what we have right here is what we call stratified mucinous neoplasia, which, if it's an isolated disease, is called SMILE, stratified mucinous intraepithelial lesion. Here, I just called it mucinous disease because I'm not sure completely if it's invasive or if it's still in situ. Now, admittedly, this is a relatively small focus, and so it's certainly not the major disease. But this is a disorder that often has accompanying squamous neoplasia, and in fact, in some situations, will lead to an invasive adenosquamous type of lesion as well. So I thought it was unusual to find these three different patterns, actually four different patterns of squamous lesion, conventional endocervical adenocarcinoma, SMILE, and potentially adenoma malignum in a single case. Now, fortunately, that's not going to distinguishing those four things is not going to significantly change the management of this patient. She has deep extension of her disease, and that's going to undoubtedly lead to a radical hysterectomy as her management. And hopefully, margins will be clear and no nodal disease will be present there. The other factor that we use in helping to guide that is the nature of the invasive disease, or the pattern. And I believe there's a little bit about that in your GYN module about so-called Silva patterns of invasion. And they're characteristically of three types, A, B, and C. The A type has essentially no reaction to the neoplastic glands. And so A-type invasion is extremely difficult to distinguish from, extensive intraepithelial disease. In fact, I think sometimes you just can't make the distinction. Whereas B-type invasion will have some of that, but will also have some areas where you get a degree of this sort of change. You get some inflammatory reaction, maybe a little bit of stromal change associated with that type of disease, angulated, incomplete glands, and things like that. And then C pattern invasion is that type of reaction is the dominant feature of the lesion. So in this case, there was just very minimal areas which could be stromal reactive type of change, a little bit of that around here. Potentially, this is a little bit of that type of change, because you see the gland is fragmented and there's a little bit of stromal reaction around there. But a lot of these areas, like here, there's just no reaction to this tumor, even though it's clearly very hyperchromatic and so forth. So those were some interesting findings from this particular case. I'd defer to any comments from Dana or from Mini or Esther about your thoughts on this case and how you approach this problem.
Yeah, endocervical lesions are, I think, one of the scariest things in GYN pathology for that for the reason, one of the reasons you just showed is that they can be so subtle. Um, and I think for that area that had minimal deviation or adenoma malignum, I could conceivably see if that was all we had and it was more towards the surface, would have flown past it as normal endocervix. And I think the context of seeing everything else there and how deep it was really helped. Typically you don't see both or all four of these processes in one, but yeah, it's a very tricky area. One thing that I always do is when I see squamous dysplasia, just because that's more common, then I pay a little bit closer attention to the endocervix to make sure there's no endocervical component. But yeah, it's really hard, I think, looking for these lesions.
So this is the P16 stain that was done on that, I think the first block that I showed you, and you can see it's got nice, strong staining, actually a lot of strong nuclear staining here. Um, and although some of these glands up in here obviously show a more heterogeneous pattern here, which would be more like what you might see with ciliated metaplasia or something like that, rather than characteristic endocervical adenocarcinoma. Um, so the P16 uh, here showed that, even your deepest tissues were positive for P16, but this was not one of the areas where we had that minimal deviation pattern. So just out of academic interest and potentially a little bit out of prognostic interest, I have requested the other block that was had the other patterns so that we could verify or determine whether or not those are also HPV P16 reactive or have other characteristics like that.
I have a question. Would you call this silver pattern A? Or
I did. I thought pretty much
okay.
everything here was A, because the only areas where there was inflammatory reaction were kind of in the midst of things, and when I wasn't sure if it was really invasive.
Mhm.
In fact, I had a hard time being confident that there was any invasion because of that. Even though there's very deep extension,
Yeah.
I first wondered if this was all in situ disease because you have such deep penetrating normal glands in many of these areas.
Mhm. So your
Uh,
clinicians are okay with just giving the extent of the disease when like without saying definite in situ versus invasive?
well, obviously they like it. They like it. It's more comforting to them if we told them it's invasive
Right.
disease. Um, but they understand the
Mhm.
difficulty. And in fact, our leading expert in cervical cancer, who was involved with the ALTS trial and many of those other things very early on, she's very savvy about pathological issues, and she understands this dilemma. So she's very comfortable with,
Mhm.
you tell us the thickness or the depth of it, and we'll be fine.
Okay.
Um, Others who understand the pathology a little less thoroughly, they want you to say, you've
Right.
got this, it's invasive, it's not invasive, it's lymphovascular invasion, it's not lymphovascular, et cetera. They want all those little
Right.
details that govern their cookbook for what
Mhm.
they do most.
Right. Yeah, one of my clinician, my surgeon, if it's like superficially, minimally invasive, less than 1 millimeter, he still wants me to say invasive versus not. And I said suspicion, I think I said suspicious for invasion because it was a cone. But he wanted more. And margins were
Well,
so far.
yeah. Yeah, well, that communication issue between what we say and what
Mhm.
they understand uh, is really a tricky thing. And I think I use the term suspicious a lot, But I've gotten to the point where when I say something like that, I will sometimes give them a kind of, this is how certain I am. This is a number. I'm like 85% certain this is invasive disease.
Right.
And if they're then comfortable, treating it as invasive disease with that level of certainty, that's their choice. But
Mm-hmm.
if I would say, can't rule out or something where I'm maybe only 60% certain that it's
Mm-hmm.
going to be invasive, then, that's their choice again. But also we can say kind of what we think the next steps ought to be or how this ought to be managed in a recommendation or something like that. If you understand those options and that it's sort of taking that into account, I'll say I'd be very comfortable with a conservative cone excision in this case, or I'd be I think this patient definitely needs a radical hysterectomy or something like that.
Mm. Thank you.
I don't always put that in the report, but I usually make sure that I've
Right.
communicated it to them either at tumor board or individually.
Mm-hmm.
Dr. Hassel, how was this picked up? Was this a PAP with like AGC or something?
I believe it was atypical glandular cell pap. Yeah.
Hmm. Yeah, I worry about those minimal deviation. I'm doing mostly the PAP, so I look at, the screening side. How do I get to children?
Well,
So,
boy, I don't think I've ever seen a case that on PAP that turned out to be minimal deviation, because those are usually deep lesions. That's how at least that's what I was taught. They present as a deep lesion, and that's how you become alerted to it because it's deep. Um, so I'd be in the same hot water with you if I was asked to make that distinction on pap smear because it's so subtle.
right. Well, that was a very, very good case.
Oh, I just want to bring out there was a chat question from V. If you have any special stains or IHC marker to distinguish in situ versus invasive. I don't know any, and I don't usually do any. Do you do anything?
I don't. Uh, I don't think there's anything that can tell you definite invasion in
Right.
this situation that we would put weight on.
Not like the breast ones versus, yeah.
Now we will, we do use in situ hybridization for HPV types on several situations, especially if there's, concern that it might be a P53 related lesion and therefore the P16 could be abnormal on that basis or something like that. But no, we're all in the same, rely on histology and good sections to be able to make that distinction. Well, we're pretty well at the end of the hour. Any last questions?
If anybody can make it tonight, we have the second session. But if it's out of your time zone, don't feel obligated to go in the middle of the night for you. Just catch the recording, but it'll be a good one.
Yeah, so we did try to do this because obviously we've got quite a few people who are enrolled in the process that haven't been able to come to these sessions when we hold it at this time. So we thought we'd, switch one to do one 12 hours later to see if that might be more convenient for some other people to join. But thank you all for being with us, and thank you, Dana. Thank you, Esther, Mini, and especially honor accolades to Exiglen for excellent presentation, a unique case. As far as future goes, we are going to move next to the mismatch repair testing module, which is a very short module. And so our next session here will be focused on that module. And that should be the next one that you try to undertake. It's not terribly long and fairly straightforward. And then we'll go on from there to the skin module, which is just being rolled out. So I think that will be the next one after that. If you encounter problems or questions, having difficulty with any of the online module, please don't hesitate to reach out to us or to Felicity, and we'll help you get any problems resolved. So we'll see you again in 2 weeks.
Thank you.
But
Thank you.
Have a nice
Thank
day.
Thank you.
Thank you. Bye bye.